Hello, my name is Dushyant Sahani. I'm radiologist at the Massachusetts General Hospital in Boston, and I'm going to speak to you all regarding a new CT technology, how we are using in the clinical care, and what are some of the challenges that one needs to overcome to apply this in the clinic, in practice. Now, first and foremost, CT is a very important modality that we use for a variety of clinical indications because of the speed of scanning, the access, the ease of use, and the quality of the exam that one generates. One of the important things to remember in CT scan that our purpose for most diagnostic exam is to enhance the contrast to noise for better lesion detection and characterization. And to improve contrast to noise, we exogenously administer contrast intravenously as well as orally for various abdominal applications. And without intravenous or oral contrast, many diagnoses won't be possible. Now, I'm showing you some case examples here of a tumor in the liver or a mass in the pancreas or this dissection in the vascular structure, the superior mesenteric artery, or looking at a leak in the stomach or a stone that is obstructing the small bowel. And all these diagnoses is possible by giving intravenous contrast. Now, the images on the top, the pair, demonstrate that how even a 2 centimeter mass is invisible if intravenous contrast is not administered. So value of contrast is key for making a diagnosis. Now, there are certain challenges with single energy CT. One most important one being we can detect things better, but when confronted with characterization of this lesion, it's often difficult. Kidney being a prototypical organ where incidental findings are routinely encountered, but characterization can be challenging. And some of this being due to the size of the lesion, the location of the lesion, and its native density. And looking at the change in the Hounsfield value is not always reliable. Now, this problem has been confounded further by introducing new organ-directed therapies like radiofrequency ablations or other type of ablative therapies that introduces certain types of changes which are difficult to interpret, and subtle abnormalities like complications or tumor recurrence detection can be challenging in certain cases. In oncology patients, these challenges are further amplified because of a lot of other complexity that exists in these patients. For example, liver is a common site for metastasis for various gastrointestinal primary tumors. And after treatment, these metastases are difficult to detect because of their native density, but also the background liver changes in its attenuation due to steatosis, making the detection even more difficult. Now, this case example shows that fact that these 3 metastases which are low in attenuation are very difficult to detect after treatment has been given, and therefore MRI is routinely used in these patients for treatment planning and surgical resections. There are other challenges like detecting peritoneal disease, especially the subtle abnormalities in the abdomen. The lymph node characterization is another example. Patients who have surgeries or radiation therapy, the differentiation of post-treatment changes from a recurrent continue to bother us, and we haven't figured out a good approach on CT to make that determination. And after treatment has been given, especially these novel targeted therapies or organ-directed therapies, the changes that we encounter are different than what used to happen with the cytotoxic therapies. So these are creating problems for single energy CT. Now, in simple terms, dual energy CT is similar to single energy CT in its acquisition. That means we are concurrently acquiring or sequentially acquiring X-rays of 2 different energies and then mainly the rigorous analysis is being applied to images. So patients' experience for single and dual energy CT is similar. The time it takes for scanning is similar, but now we have capability of doing more advanced processing on those images to generate material-specific images and these virtual monochromatic images that have found value in clinical care. And there is enough clinical information and data in the literature to support the use of these advanced images. Now, there are a few areas which I feel, in abdomen especially, these images have value. One is in tissue composition. Cancer imaging is a very important application, especially for better detection and characterization of abnormalities. Vascular imaging is the third major category. And here we have opportunity to improve the quality of vascular exam, or we can simplify the protocols, especially by eliminating some of the phases of acquisition or reducing the iodine dose and radiation dose for certain patients. Now, first, if we look at one common application where CT is routinely used in North America is in adult patient with kidney stone. And this problem inflicts millions of patients, and the prevalence of this disease is rising to the extent from 1960s to now there's more than, the prevalence has more than tripled. And management is complex for these patients. And one of the treatment decisions is based on the stone composition or how hard or porous the stone is. Now, uric acid stone constitute about 10% of these kidney stones, and these can be managed medically. We can dissolve these stones by changing the pH of the urine and altering patient's diet, whereas the stones of intermediate hardness require shockwave lithotripsy, and those who have higher amount of calcium, those stones are hard to break and they require more invasive therapy. Now, with the dual energy CT, because the uric acid stone are composed of lighter elements, they behave differently on two energies compared to the calcium stone. And therefore, on material density pairs, one can characterize these stones reliably. For example, here on this image on the top, you're seeing a pair of water and iodine image of a uric acid stone, where the stone is visible on water image but not visible on iodine image, whereas the bottom pair shows that stone is visible on both the material density images, confirming a diagnosis of non-uric acid composition. And this information can be applied to clinical care, as I show you a case example from two different patients. One, on the top, you notice that in the material density pair, the stone on the iodine images is almost invisible except for a fraction of calcium in it. And this is predominantly uric acid stone with a little bit of a contamination of iodine. And when this was medically managed within few months, there was 30% drop in the stone burden. Whereas in this elderly gentleman with the uric acid stone in the left kidney, after a few months of medical management, there was a complete resolution of stone. There are advanced capabilities on the workstation, such as estimating effective atomic number of the material. And as we know that denser the stone, higher the calcium content, their atomic number is higher. So one can substratify stones into the soft stone, intermediate stone, and harder stones for better treatment decisions. Now, to make this happen in our own practice, we use a approach, we call it as a screening and a targeted approach combination. So first of all, we do a screening, low dose images through the kidneys, ureters, and the bladder, and then we target the area of stone with the dual energy. And with this, we can accomplish both detection and characterization at a substantially reduced dose, which is acceptable in clinical practice. And here I'm showing you the dose data from the publication as well as from ACR registry. And what you notice is the red bar is the dose that is from the American College of Radiology registry, where the doses from various sites have been estimated. And when we can compare that single energy filtered back projection doses in our practice to begin with are substantially lower. And by using the dual energy CT by our protocol, the doses continue to be lower than a single energy CT. So dual energy CT does not increase the radiation dose. If anything, it keeps it same or drops the radiation dose and provides the additional benefit for stone composition. Now in tumor imaging, there are tremendous benefits in improving diagnosis. Now I'm showing you this first case of a 63-year-old woman with a newly diagnosed melanoma, and as we know, melanoma is a deadly cancer, and accurate staging is desired for treatment selection. Now the top row here are images from a 140 kVp single energy acquisition, and here I find it difficult to detect tumors within the liver, whereas on the bottom row of the material density iodine images, several hypervascular lesions can be visible both in the right and the left lobe, and some of these lesions are as small as 5 millimeters in size. So clearly, having the material density iodine image provides that opportunity to improve detection by looking at the distribution of iodine. On a single energy images, we rely on the composite attenuation of the tissue as well as the iodine within the pathologies, whereas on iodine images, we are looking at the distribution of iodine. Therefore, the contrast to noise is better, enabling better visual detection of these subtle abnormalities. Now, this is another case with a different type of a risk factor. In a 55-year-old with hepatitis B cirrhosis, screening is often performed for detecting hepatocellular carcinoma. And the diagnosis of hepatocellular carcinoma is based on enhancement of the lesion in arterial phase and washout in the venous phase. And if that criteria is not met, then either a follow-up imaging or biopsy is performed. And here in this case on 140 kVp images, on the arterial phase, we don't see clear arterial enhancement, but on the venous phase, we notice there is washout. So this lesion is not fulfilling the laid down criteria for hepatocellular carcinoma on images. Now, when we look at the monochromatic images, there is improvement in contrast because we can appreciate more enhancement as is shown by the arrows in the right lobe, and the washout is also more visible. But when we look at the material density iodine images, both the grayscale as well as the color overlay, the arterial phase enhancement in the lesion is much more visible. There is less of a question of the arterial phase enhancement, and even the washout is obvious. So this is a benefit of the technology for improved characterization of hypervascular lesions such as metastasis and hepatocellular carcinoma. Now, this is a 65-year-old gentleman who has prostate cancer where CT is being performed to look for metastasis, and typically in prostate cancer, the metastases are to lymph nodes or to bones. Now, in this case, we incidentally notice an abnormality in the tail of the pancreas, which is less visible on these single energy images, but when we look at the grayscale and color overlay material density pair image, a centimeter size hypervascular lesion is visible in the tail of the pancreas as pointed by the red arrow. And this is more than likely a incidental neuroendocrine tumor of the pancreas. This was biopsied and it turned out to be a neuroendocrine tumor, and this is being followed right now. This patient also had an MRI, just to make a point that on MRI you see a similar finding. The point being here, the contrast, what we achieve with the new technology using the dual energy processing is matching that of an MRI in certain organs and clinical situations. The same application can be extended to other clinical challenges like screening for hepatocellular carcinoma. Here on the top, I'm showing you images of a patient with cirrhosis and high risk for hepatocellular carcinoma. The yellow circle points to hypervascular lesion, and if you pay attention to these lesions on the dual energy processed monochromatic images of low energy, shows those lesions far better than they are visible on the early images. Moreover, there are additional hypervascular lesion in the segment 4 of the liver as well as in posterior aspect of the right lobe. One can begin to appreciate on the monochromatic images. Some more examples of different patients with different problems. Here, another patient with a lesion in the tail of the pancreas on number 2. I'm showing you the color overlay and the grayscale images of a small 5 millimeter neuroendocrine tumor in the tail. And number 3 on the right images, one notice there is a neuroendocrine tumor in the tail, better seen on the monochromatic images and iodine images. And in addition, there is a small lesion in the head of the pancreas, which is difficult to appreciate on a single energy, but one can reliably see on the processed dual energy images. This is an example of the value of dual energy CT in improved detection and staging of tumors in the center of the liver. This patient who presented with jaundice had a soft tissue abnormality at the hilum, but there is also biliary obstruction. And the question is, what is the true extent of the lesion, and if it's involving critical structures in the vicinity like vessels and veins and arteries. And that is difficult on a single energy images. And here on these processed material density pair images from dual energy acquisition shows the true extent of the lesion as well as invasion in the liver parenchyma, similar to how we see on this contrast enhanced MRI image in the bottom, where one can match the contrast that we can accomplish with MRI. So this case further amplifies the value of new CT technology in better tissue characterization, better staging, which was earlier the domain of MRI, and we can certainly add value to CT scan. There are some new post-processing approaches by looking at the spectral curve. These are, in essence, are enhancement curves, and by placing a region of interest within the lesion, we can assess if these are benign lesions such as vascular malformations or hemangiomas that match the curves of vascular structures, cysts that do not show much changes on different energy X-ray images, or if it is a tumor which follows more of an enhancement pattern of normal liver parenchyma. So these are some additional features that are available that one can apply when needed for better tissue characterization. Now, just to extend the role of the technology in other areas, for example, incidental renal mass detection and characterization. Now, in this case, 75-year-old gentleman with history of abdominal pain had a CT done. And here we noticed there is a lesion in the right kidney, as shown by the yellow arrow. The question is if this is something you can leave it alone, or this is sinister, like a renal mass that might require further workup or management. And on the unenhanced and contrast-enhanced images, there is suggestion of this lesion being hyperdense, but the enhancement is unclear. On these dual energy images, on the iodine images, one can see the distribution of contrast in the lesion, so the images makes you more confident of enhancement in this case, so appropriate management can be recommended based on these images. And more examples of lesions, small lesion less than a centimeter in the kidney, we detect. Characterization is a challenge. I'm showing you the single energy images, and there are comparable dual energy images, and you can see on the, just looking at the material density iodine image, one can be confident about distribution of iodine in the lesion that is essential for making a diagnosis of a solid lesion. Another example, in a 52-year-old who has a stent placed in the right kidney. The right kidney is atrophied, and you can see there is thickening of the renal pelvis epithelium and the wall. There is always a question if there is inflammation or a tumor, and here and also there is artifact from the stent. So on the material density iodine images, which are in the bottom row, one can see that the urine in the renal pelvis is suppressed. We can suppress the artifact. The stent is not visible on these images, and the lining of the renal pelvis is better appreciated, that it is smooth. There is no nodular changes, which is more typical of a tumor. So certainly helps in better assessment of these type of patients. Now, this is a 45-year-old who presented with abdominal pain, and on an unenhanced exam, there was evidence of hemorrhage. Here I'm showing you images from the right side of the abdomen. We can see the right kidney, and inferior to the right kidney, there is an area of hemorrhage. There are some other areas medially along the aorta, so it's not clear if some of this is tumor. So when we look at the post-processed dual energy images, we learned that the big lesion anterior to the right psoas muscle is hemorrhage. There is no iodine in this lesion, whereas two of the lesions to the right of the aorta, as shown by the yellow arrow, have iodine within it. So those are tumors. So one of the tumors in the retroperitoneum had bled. And these images enable me to make that determination and also guide my interventional radiology colleague to biopsy areas which are enhancing and spare the areas which have bled. Patients who have been treated with targeted radiotherapies is another challenge we are confronting with on conventional CT. The determination of the true extent of the lesion as well as the treated zone remains difficult given the similar enhancement and attenuation with the normal parenchyma. Here I'm showing you images of low KEV monochromatic images where we can see there is increased vascularity in the liver parenchyma, but it is not altering the texture of the liver or contour of the liver. But the yellow arrow points to a small area, low density area, which is likely the tumor that has been treated and it shrunk. And now the bottom images are the grayscale iodine and the color overlay images, which shows basically the treated zone that is seen as hypervascular area due to hyperemia from radiation, and very small lesion in the treated area, which is response to therapy. So these images enable better detection of the true extent of the tumor and response to therapy, which is otherwise difficult on the single energy images. There are various other applications, whether it is lesion characterization and detection in the liver, renal mass evaluation, pancreatic mass evaluation, adrenal lesion, vascular imaging in every body part, looking at endoleaks from abdominal aortic aneurysm and post-repair leaks, as well as for kidney stones. So there are a lot of clinical reports and research publications supporting the value of these offerings of dual energy CT. Moreover, there are other materials in the periodic table. Some of these materials are actually present in the body in the form of certain diseases, like iron is present in patients who have increased iron overload, either due to transfusions or a congenital problem of hemochromatosis. So these diagnoses can be possible in the future. There are contrast material that can be generated with new materials, and that will create new opportunities for imaging with CT. We might have in future opportunities to do molecular imaging, which is currently a domain of PET or MRI. So there are certain considerations, like with any new technology, workflow being an important consideration, and they are also relevant to dual energy CT, and there are challenges with the scanner availability, given dual energy is not a routine application yet. Only some of the scanners have these capabilities, so it's challenging for us to schedule some of these exams. The technologists need to be trained with the scanning and post-processing. The radiologists need to understand how to interpret these images, what is these images mean. for clinical care. So there are certain workflow challenges that one needs to confront with. And these can be overcome by creating a team. Like anything else, for dual energy program, one needs to have a team of radiologist champions, technologist champion who will oversee all the adoption of various protocols, but also will work with the radiology champions to make these changes. Closer collaboration with the vendors is needed to enable workflow and better post-processing software and programs. And to make this workflow easier in our practice that has 4 dual energy CT scanner, and we are likely to have more of these scanner, we created disease-specific protocols, and some of these I have listed here, but it basically falls on those 4 categories that I mentioned earlier. And we get dual energy application for any time the patients are coming with these indications. And the processing is performed by the technologist on the scanner console, and these images are available on PACS. And these, to minimize number of images, we create the monochromatic images and material density pairs based on the clinical indications. So arterial phase acquisition will have low KEV monochromatic images, whereas portal venous phase will have an intermediate KEV monochromatic images, and every patient gets a material density pair. And occasionally we have to go to the workstation for advanced post-processing. Now, despite the challenges I mentioned, because of the clinical offerings and various benefits that I mentioned, the utilization for dual energy CT in our practice continues to grow. Now, the data which I'm showing you on this slide is mainly for cancer follow-up indication. And as you can see from the color-coded bar diagrams, in 2012, only 21% of our exams were scanned as a dual energy acquisition for cancer follow-up indication, whereas in 2015, 67% of exams were scanned using a dual energy acquisition. So this is a testament to the value this technique is adding in clinical care, and how we have engineered the workflow working collaboratively with our CT vendor. And this has not added to increase radiation dose, as many have this perception that since we are scanning using 2 different energies, it will double our radiation dose. In essence, the radiation dose remains same, or it is slightly lower than what we get from a single energy acquisition. Now, these color-coded bars are the dose comparisons based on thousands of patients that have been scanned in our own practice using single energy as well as dual energy, and one can see the comparison with the American College of Radiology directory doses is that our single energy filtered back projection and iterative reconstruction doses are quite low, and the dual energy doses remain comparable to these 2 single energy applications, but remain substantially lower than the national averages. So one can accomplish a high quality diagnostic exam without necessarily increasing the radiation dose. Now, this case kind of sums up the value I mentioned earlier in my discussion. So 45-year-old who was visiting houses in the neighborhood to canvass for election, and in Boston being one of the places that encountered one of the harshest winter this year, while being in the front of the house, a large slab of ice from the roof actually fell on her, and she had an unfortunate accident with a lot of fractures on the right side. And when she came to our hospital, we scanned her using the dual energy CT, and here we noticed a lot of changes in the soft tissues on the right side, the rib fractures, but also we discovered a abnormality in her right kidney. And one of the questions is always if this is a trauma to the kidney, and that is an area of bleed inside the kidney. Since this was done as a dual energy acquisition, we had the capability to process images, creating these virtual unenhanced or water-only image, and here we noticed that area of abnormality in the right kidney is not higher density than kidney, which we expect in hemorrhage. And on the material density iodine image, there is iodine within the lesion. That means this is not a hemorrhage. This is a tissue, which is different tissue that is enhancing. And on the monochromatic coronal image, one can see this lesion is changing the contour of the kidney, but also it's very well defined. So this is an incidental renal cell carcinoma detected in a patient who had a trauma. And we could make a reliable diagnosis on a scan because we had that capability of a dual energy acquisition. Otherwise, this patient would have required a repeat study with a multiphasic protocol to answer all these questions. I think with that, I want to sum up saying that the expectations from our clinical colleagues have changed. We need to go beyond diagnosis. Not only we need to give better diagnosis with CT, but we need to also do a better characterization. We need to facilitate treatment decision making for a variety of clinical indication, oncology being one notable example, and vascular imaging being the other one. We also need to develop images as a biomarker for risk stratification, for better prediction of outcome. And we are seeing examples of some of these image biomarkers in oncology and some of the vascular workup. But with all these advances, we need to provide a safe environment for our patients, both from a radiation standpoint as well as from contrast media safety. And I think having these advanced capability with CT gives us that opportunity to meet this clinical expectation, but also provide the safety standards that our patients and referring physician seek from us. With that, I want to thank you all for listening.